Everyone, this is Marika from Hemisphere, and today I'm so excited because I've got Jessica Drummond with me all the way from Connecticut, and we're on a 12-hour time zone difference, so we've managed to somehow make this work, which I did get a little bit scared that with daylight savings and things that we wouldn't make it happen, but we made it. And today we're going to talk about constipation in pregnancy, and the reason this topic came up was I get a lot of women asking me about solutions for constipation in pregnancy. And I think it's just such a common thing that happens. And I reached out to the women's health physiotherapy community and said, does anyone have any blogs? Does anyone have any information easily accessible? And everyone said, well, you've got to talk to Jessica because, she's the lady who knows it all. So I thought we would pop online and have a chat about, some of the symptoms that people might experience and maybe some practical solutions. And so that's what we're going to talk about today. Awesome. So before we do that, I'll just quickly introduce Jessica. And if you want to pipe in and add anything at the end, please feel free, Jessica. But I'm going to more or less read a little bit of your bio that I took from your website because I think it's a fabulous description. But Jessica is the founder and CEO of the Integrative Women's Health Institute. She's got over a decade of experience as a women's and pelvic health physiotherapist. Is that what you say in America? Or pelvic floor?
Yes, we used to be women's health specialists, but of course we see men as well. So it's a little bit vague. There's not a decided term, but I would say pelvic health.
Pelvic health? Yep, I think that's where we're heading as well. So she owns her own private women's health clinical nutrition and coaching practice, which gives her a unique perspective on the integrative conservative management options for pelvic pain management, which I think is something that's a lot of people haven't done traditionally. So this sort of more holistic approach to pelvic pain, I think is becoming more common, but certainly Jessica's been a trailblazer in that area. So bringing in those nutrition and lifestyle management aspects, as opposed to just the nuts and bolts and muscles and joints and nerves, which we as physios tend to concentrate on. So Jessica was educated at the University of Virginia, Emory University, Institute of Integrative Nutrition, and Duke Integrative Medicine. So you've got a lot of degrees.
True. And I just got a doctorate at Maryland University of Integrative Health. So yes, I've got plenty of 100 years of education.
I'm guessing there's some university debt somewhere that we don't need to talk about tonight.
Right. Right. Yes.
I was looking at doing my PhD at the moment. I'm still trying to get my head around that. So Jessica's really taken all her knowledge and experience, and she's now working in sharing that, I think, with a lot of the health and fitness community and teaching them how they can use these skills with their clients as well through the Institute. Do you want to talk a little bit about the Institute?
Yeah, so our institute is primarily designed to offer educational options, mostly for our physical therapists, fitness professionals, nutritionists, health coaches, and we also have gynecologists and PM&R physicians and, PAs and nurse practitioners. PM&R, physical medicine and rehab physicians. Do you have that in Australia? Yeah, no. The whole gamut of specialists, whether it's in sort of traditional medicine or more holistic medicine. And a lot of people are crossing that gap more and more these days. So we do a lot of professional training. The vast majority of it is online and self-paced. So we do have students from over 40 countries. I think we're almost up to 50 now. And because we don't always have to deal with time zone issues, which is nice. And there are times where I travel, like when I came out to Melbourne last year to teach in person. I also have a small clinical practice that's virtual and global. So I do see patients from all over the world in this virtual model. But I'm actually transitioning that to do a little more in-person work with patients in this coming year, because I do think it's nice, there is something very important about the physical assessment whenever possible. Now, it's not always possible because, there's not always access to the kinds of clinicians that patients are looking for when they live in more rural or underserved or further away areas. So I think clinically I try to do a little bit of both, but the vast majority of what the Institute does is professional level training on a number of different subjects in integrative women's health.
And I would really encourage everyone who listens to this is to get onto her mailing list. Jessica provides a lot of information, so blogs and videos and webinars, all sorts of things. So, you know, she also provides a lot of free information for people who want to access that. So definitely jump on board that. So I'm just curious, Jessica, because as I was saying so early on, you're a bit of a trailblazer in this area, combining these, you know, different aspects of healthcare into a physiotherapy model. How did it evolve to become what it is today? How did you get to this position now?
Well, I started my practice in physical therapy in 1999. And originally I was specialized in sports medicine, orthopedics, as a lot of us are. I was an athlete as a kid. You know, you go to PT school because you just, you know, you get an injury or something. In high school, I worked in the training room with collegiate athletes at University of Virginia. And then pretty quickly, though, within about the first 3 years of my practice, I began to essentially specialize in women's health. But a lot of that is orthopedics. You know, you've got pelvic ring, pelvic girdle issues. You know, I had patients that had breast cancer surgery and then had shoulder issues. And then slowly, you know, as you get more involved in women's health and pelvic health, you learn a lot more about pelvic pain conditions like endometriosis and vulvodynia and incontinence. And I worked for many years at a specialty women's hospital where, you know, we saw perinatal women primarily. So that hospital delivered about 10,000 babies a year, which is 1 an hour around the clock, wow. on average. So we did everything there. We did high risk pregnancy. I sometimes would do manual therapy during labor, you know, but most of the work was outpatient in pain issues related to pregnancy, whether it was more orthopedic spine pain or pelvic pain. But, you know, at that time, so this was, you know, I said in the bio, I was practicing a decade. It's been almost 2 decades now. So that was before my first daughter was even born, and she's 14 now. So, you know, at the time, pelvic pain was even far more mysterious and difficult to treat than it is now. And it is still challenging. Yeah. But what happened to me is my oldest daughter was born in 2003. And around that time or after, what happened to me, I had kind of a hormonal crash, which the more that I now understand about hormones and interaction with the immune system, probably what happened was a reactivation of Epstein-Barr virus. So when I was a teenager, I had mono a couple times. I was, as I said, kind of a high-level athlete and burned the candle at both ends and all of that. And so since my pregnancy was uneventful, I had a perfectly fine delivery, but postpartum was rough. And so I was really fatigued. I was getting all kinds of colds and flus, and I started having really severe anxiety. And basically what my Western medicine colleagues had at you know, even very highly skilled and specialty hospitals for me were things like, oh, try an antidepressant, or here's a sleep medication, or here's another Z-Pack for the 5th sinus infection you've had this you know, season. And I could tell that wasn't it. First of all, the medicines didn't work. Yep. And so I, because I was fairly desperate, you know, several years into this, I went back. So the specialty women's hospital that I worked in was in Houston, Texas. And when I was quite sick, we kind of moved between Michigan, North Carolina. My husband's a consultant. So we've moved like almost every year from the time my daughter was born until she was like 12. But I was back and forth to Houston, and there was a physician there that we would refer our patients from physical therapy who were kind of like the difficult, curious patients. You didn't know what was wrong with them, right? And now we have such a better understanding that, you know, people really aren't making this stuff up. They're just, there are these challenges that we don't understand. So I essentially self-referred myself to this woman who we sent all the challenging patients.
You said, I'm a challenging patient.
I was like, suddenly I'm a challenging patient for sure. So she was a very early functional medicine physician. She trained in Canada, and she had done some training in China, and her son was a an acupuncturist, and he worked in her office. And I essentially lived there for 2 years. Thank God their office was like 2 blocks from my house. And I found out that I had what was known as adrenal fatigue at the time. We now understand, again, that's more complex. It's really hypothalamic pituitary adrenal axis dysfunction. But basically, when your brain, there's a communication system between your brain and your adrenal glands, which is responsible for stress buffering. And that system can become overwhelmed either sort of acutely or more chronically over time. It has to do with blood sugar balance. It has to do with stress management. And so I had to change my diet fairly significantly from a pretty, carb-based vegetarianish person, high sugar, high carb. I thought of myself as a healthy eater because I was very, I exercised a lot, but really I was eating way too much sugar, processed carbs, that kind of thing. Because at the time, it was like carb loading before your races, right? You remember that?
Yeah, absolutely. Didn't work for
me. Yeah, I know. And it was terrible. So I had to balance my blood sugar. I had to completely change my relationship with stress. And I had to actually learn even more about nutrition than she knew, because she had sort of a cursory understanding of that. She was much more skilled in nutrient supplementation and things like that. But I also had infertility at that time, which is why my kids are 7 years apart. And I did get pregnant once in between. And during that time, which Lord knows how, because I was like so sick, it's like, but I had a fairly early miscarriage. But at the time, she couldn't give me the supplements because I was pregnant. So we began, so I began to take this more wide ranging path of self-healing, which was mostly about rest, changing my relationship with stress, changing my relationship with exercise, eating a ton more protein and fat than I had ever eaten, and still a lot of vegetables, which I always had eaten, which was good. And, it was a big lifestyle shift. I had to change my kind of type A-ness. And then so what I began to realize, so bringing it back to my patients, was that if I could so dramatically improve my hormonal health, and I naturally got pregnant once that happened. I never used any assistive reproductive technologies or anything like that. Once I got my health back and my hormones balanced, I felt so well. I mean, in a way that I had never felt well in my life. I always thought of myself as healthy. I was an athlete. I was, I had busy jobs. I was a great student, but I never realized how much I was kind of burning myself out.
You're like, this is how I'm supposed to feel.
Yeah. Yeah. So it took a while, but once I got there and once I recognized that these really basically two fairly simple tools, nutrition and lifestyle medicine and exercise, but in the right way, completely changed my hormonal health. I knew that, there was an interaction between hormonal health and pelvic pain. And so I began to kind of play with some of these ideas with my patients, having really only my experience and my kind of self-knowledge, which is why I eventually went back to get a doctorate in nutrition, because, there's almost only so much you can take to apply broadly. But what I began to realize is that some of my patients would have some fairly simple nutritional challenges that we would change, and quickly. Someone who had been either plateaued or resistant to physical therapy treatment for their chronic pain, especially in pelvic pain, would have resolution quickly. Not in every case, it's not like a flip switching in every case, but sometimes it was. I mean, I had one patient who avoided a hysterectomy just because she stopped eating dairy.
I was actually going to ask you, are these predominantly those who have pelvic pain from things like endometriosis, or just general pelvic pain from anything?
Either way, because, the challenge with pelvic pain is the underlying components are often many things. People with endometriosis often also have IBS, and they also often have vulvodynia or painful bladder syndrome or IC. So it's all of it. It could also be just general period pain. It might be someone who doesn't have endometriosis at all. It could be someone who has pelvic ring pain, a more musculoskeletal issue. Could be someone who has low estrogen, and so they have pelvic floor weakness. So all of these things in the pelvis, so many systems come together that it really, and they often overlap. You have a lot of comorbidity with pelvic pain and also with psychosocial issues, anxiety,
Yeah,
depression,
absolutely.
fatigue, other autoimmune diseases. So it's really all of that. And what we do from a nutritional approach is strip it down one system at a time.
It makes so much sense. I mean, I don't deal a lot with pelvic pain as yet, as yet. I'll hopefully be heading in that direction. But I have two celiacs in my house, and it's really interesting when you see the effect of the wrong types of food for people and the influence on, brain health, energy levels, joint pain, all these other sort of systemic symptoms that pop up or random symptoms that come out just through a reaction to a food causing an inflammatory type process. It's really interesting. So it makes a lot of sense, really, when we sort of think about it. But because I guess that's not really been in a traditional, physiotherapy modality, I guess, did you find that you got a lot of pushback or resistance to these ideas, or have people been quite quick to take them on board?
Well, at first, when I just sort of added this to my practice because I had patients that were plateauing and I didn't know what else to do with them, I wouldn't say there was resistance. It was just that I didn't have the confidence to make super skilled recommendations. So I was kind of like, hey, you might want to try this. And they wouldn't do it, of course, because they were like, she doesn't know what she's talking about.
Dairy,
and then
I want my cheese.
Yeah. And then exactly. Or they would say things like that, like, I can't live without dairy. I can't live without ice cream. But then they would, sometimes they would just try it, with chronic pain, you're willing to do a lot of things, at least for a short period of time. And so, yes. So I think patient wise, it was a toss up and it had more to do with my skill level at the time. Now I don't find that pushback. We have conversations, again, a lot of times I see very complex cases now. So it's more like, well, this, it's not a cut and paste protocol. We have to work through challenges. So it's almost never just like take out dairy and like, oh, you're healed. It's like almost never like that, but it is, but it can be a pretty big shift to just do a pretty simple elimination diet in, I would say, like 60 to 70% of cases.
Sure.
So, that's nice and reassuring. But then in terms of my colleagues, yes. At first I got a lot of pushback. So I was started to do this, out loud in 2009 or so, and maybe even 2008. And like any talk of the connection between the inflammatory response and chronic pain.
Woo-woo, fluffy stuff. What?
Oh my God. I just started going back on Twitter maybe 2-3 months ago because I was so sore from the number of people who would like attack me just out of the blue. So yes, at first there was a lot of attack, a lot of this is crazy. This has nothing to do with it. Everything's based in the brain, which I agree. But if your brain's inflamed, that's an issue. Yes, there was a lot of professional pushback at first, but, honestly, it bothered me to some degree at first, but it didn't really slow down what I was doing because I knew personally that they were just wrong. I didn't know how to explain it as well as I do now. And even now, we don't have as much data as I wish we did to really back up everything, but we don't have enough data about everything that I wish we did,
Yeah,
anything.
Absolutely.
So, we have to kind of use that combination of clinical judgment, data, guessing, patient response, and now over time, because I've been doing this and refining it for nearly 10 years, it's much more accepted. And I feel like my colleagues are very much on board. And if anything, they want to learn too. So.
Oh yeah, they're
Yeah.
hitting you up for questions on just about everything on Facebook these days.
Right.
She's our go-to lady. So we're going to talk about constipation and in pregnancy. But before we kind of talk about the sort of treatment options, can you just explain what constipation is? Because I think people have a different idea as to what's considered normal in terms of how often people, you should empty your bowels and what it should look like and the consistency and things like that.
Right. So if we look at the kind of general GI Western medicine literature, I think there's consensus that any bowel movement from essentially 3 times a day to 3 times a week that are Bristol. So is your audience familiar with the Bristol scale? Or
Some will be and some won't be.
okay, so the
But I can
Bristol
put a
scale.
picture.
Okay, yeah. Well, here's a picture, but basically the Bristol scale describes that consistency. So it goes from very kind of rock solid little pellets, constipated kind of hard stool to loose diarrhea like stool. Right in the middle is Bristol 4, which is essentially a long snake-like consistency of more like a not too overripe banana. And that's what you're looking for. That's like the holy grail of poop. Right. So, and kind of a pretty big snake-like poop. Now, from a more integrative, holistic standpoint, naturopathic perspective, at least once a day, having a bowel movement is much more optimal. Not 7 times a day, but 1 to 3 times a day would be better. Because the problem is if you're not pooping for every 3 days, you're recycling estrogen most likely, which is going to be a more estrogenic estrogen, so potentially toxic. If we're talking about retaining estrogen, you're just simply not eliminating
bowel for too long. Is that what you mean? You just reabsorb.
Well, yeah, and so when you don't have enough fiber, you actually have an enzyme that will cleave estrogen again and reactivate it in the gut, in the colon. So you're actually recycling a stronger metabolite of estrogen that we don't want. We already have too much estrogen exposure in the environment from plastics and environmental chemicals and, even just in the water. In the United States, 80% of women are on birth control pills at some point. All of them pee. Mm-hmm. None of our water systems filter out all of that extra hormone and things like that. So, so we have a ton of environmental estrogenic exposure. So we don't want to be recycling our estrogen. We want to be eliminating it. We need estrogen. I'm not saying we don't want any estrogen, but we don't want to be recycling. And the same thing with any other, toxin, whether it's a medication or an endotoxin, something metabolizes and you're just keeping it, or something we're exposed to in the environment. I think it's also important to just note that, we have so much chemical and metal and environmental toxic exposure just from drinking water and, being surrounded by EMFs and other chemicals. There's just so much more in our environment than there was even 50 years ago, certainly 100 years ago. So our body needs to eliminate that on a consistent basis. So that would be the optimal goal, is to have a Bristol for poop approximately 1 to 3 times a day.
Awesome. And I think when you speak to a lot of people who have good bowel habits, they do tend to go the same time every day. They have that regular, I've had my coffee in the morning, and then, I know some certain people in my family, I could set a clock by their actions, which I think is, it's actually a good thing. But why do women have constipation? Why do they suffer it more in pregnancy itself?
Well, it's funny, the progesterone, they do for 2 main reasons. One is hormonal shifts. And it's a little bit unclear in the literature as to which hormone is more involved in constipation. So progesterone slows motility a bit. That could be an issue, and progesterone levels are fairly high in pregnancy and also in the luteal phase of the menstrual cycle. So just the second half, right after ovulation. So for some women, their bowel habits just change hormonally even month to month. Or times of the month. They don't even have to be pregnant. But in some animal studies that are more recent, it actually seems that estrogen is more the driver of constipation. So it's hard to say which hormone is the driver, but the hormonal changes certainly are one potential driver. Another common driver,
Yep.
What?
And that just slows down the movement through the gut.
Right. So you're slowing motility. A second potential driver is increased iron. Not birth control pills. Prenatal vitamins, contain a fair amount of iron, and that really slows down gut motility. Also, pregnant women, especially first trimester, they don't feel very well. So they're not eating a lot of fiber in many cases. They're kind of like sticking to, the cracker, chicken broth diet. And that can be a problem because without an adequate fiber, you can't be as mobile. In first trimester, you're also very sleepy. You may not be exercising as much. So exercise definitely impacts motility. Exercise also impacts the gut microbiome. So when you change your diet and exercise habits, just because of how you're feeling, especially in first trimester, that can change motility as well. So those are the core causes that are specific to pregnancy.
And I certainly hear that a lot with the iron, because a lot of clients I hear will, find that they're low on iron, go down the generic iron that they're usually prescribed tends to cause constipation a lot. And the naturopaths that I work with tend to have other ones that they recommend that don't tend to have quite the same effect. What do you think women who suffer from constipation in pregnancy should do to help get things moving along? And should they go see their doctor? Should they go to the pharmacist? What's your recommendation?
Well, I think you can definitely start with lifestyle strategies. So one, if you do need to take added iron, in the US, it's fairly standard that everyone takes added iron. In other countries, there is a measure. So I don't know, in Germany, I know that essentially there are 3 levels. They'll do a blood work to see if your iron is low. And if it's not, you don't need added iron. If it's moderately, they'll give you a smaller dose. If it's very deficient, they'll give you a higher dose. So do they test that in Australia? Yeah. So that's better, because if you don't need the iron, it's keeping it out is better. In the US, it's just kind of standard. So I guess properly prescribing the iron is key. There are different iron supplements. Some are liquid that are a little less constipating. Generally, though, most of them are pretty constipating. But what you can do is, let's say you are feeling more nauseous, tired, that kind of thing. Instead of that cracker and chicken broth diet, if at all possible, stick to a more nutrient dense diet, but eat more often. So you might eat small amounts, even six times a day or something, 4 to 6 times a day. Still vegetables, protein, healthy fats, especially omega-3 fats, because we're building a brain right now. Salmon, walnuts, flax seeds can be helpful. Flax seeds can be estrogenic for some women, but as long as you're pooping, that's not too bad. Chia seeds, same thing. But really trying to find some fiber-based foods that you can have with a protein and a fat to keep the blood sugar steady, which will reduce that nausea symptom. It'll also moderate fatigue a bit and keep your bowels flowing, because we've got to have, good quality fiber to feed the bacteria in our gut to keep a nice balance there. You can also add probiotic supplements. The safest kinds of probiotics to take in pregnancy, which have been well studied, are a combination of lactobacillus and bifidobacteria species. So just kind of a multi-strain of those 2 types of probiotic bacteria is what I would recommend in pregnancy. Magnesium can also be very helpful. Magnesium glycinate is a little more well absorbed, but magnesium citrate is going to encourage looser bowels. So the combination of those, and do that in collaboration with your physician. Magnesium tends to actually keep the uterus quieter, which is a good thing. So to avoid preterm labor. But, it can impact the smooth musculature around the uterus. So make sure we're not overdosing. If you're getting too much magnesium, you can actually push it over to loose stools, and that could potentially be a problem. But, a modest dose of magnesium citrate and combine it with glycinate for better absorption. Probiotic bacteria I talked about, keeping
Sorry,
your
so the magnesiums you would take more to what if you have the constipation to get things moving.
moving,
You
correct. If
wouldn't
you have
take
diarrhea,
long term at all.
well, magnesium you can, but at first, so during pregnancy, you can take magnesium to get your bowels moving for sure, especially magnesium citrate. It is a common nutrient that is deficient in many people. So it's not a bad idea to add in general. And if you're taking calcium supplements, which can be good during pregnancy, because of course you're creating a whole new skeleton. And if you don't have enough calcium, your body is going to take it from your bones. So taking calcium supplementation in pregnancy is reasonable, but you have to combine calcium supplementation with magnesium supplementation. So about half as much. So let's say you're taking 600 milligrams of calcium, you want to be taking at least 300 milligrams of magnesium. Otherwise, the calcium can deposit into the vessels and not the bones. And that increased risk for cardiovascular disease.
Oh, that's not good.
No, so you don't want to just take straight calcium supplements. I would also combine them optimally with vitamin D3 and vitamin K2. So if you're going to take any calcium supplements, you want to ideally combine that with half as much magnesium, a maintenance dose of D3, which could be anywhere from about 800 milligrams to 800 IUs to 2,000 IUs a day, and up to about 45 micrograms of K2.
And
So that would be a good combination.
Most doctors and pharmacists would be aware of in terms of the combination?
No, probably not.
You heard it here.
Probably not. But naturopaths, possibly. Yeah. If your doctor is telling you to just take calcium supplements, it's potentially dangerous because the calcium we have good data that shows that the calcium can then deposit in the vessels. Ideally, you'll be getting enough calcium in your food. Yeah. But, many women can't tolerate dairy, especially if they're constipated. Dairy can worsen constipation. And better sources of calcium might be things like black sesame seed or leafy greens, but a lot of women aren't getting enough to have adequate calcium. There are good, some women, even who can't tolerate dairy, can tolerate yogurts, plain organic yogurts. They're more easily digestible because since they're partially digested already. Yep. Unless you're sensitive to the protein in dairy, which that's not going to help. So
are those risks with taking calcium, is that just in pregnancy or is that for the general population?
General population. Yeah.
Yeah, interesting.
Yeah. So, but in pregnancy, it's not a bad thing to take calcium supplements because a lot of times women do need calcium supplementation. It's just that we want to make sure it's balanced so that all of those nutrients are going to guide that calcium to the skeleton, not the vessels. That's the key.
That's interesting. Have you got any toileting tips in terms of positioning or breathing? Or because I know that, you would hear this a lot as a pelvic health therapist, is that a lot of people bearing down, and obviously we have concerns that bearing down through a pelvic floor might lead to other issues. What are your sort of top tips for women for emptying the bowels?
Well, definitely positioning. So do you have the Squatty Potty in Australia?
We love the unicorn.
Yes.
The pooping unicorn. Yeah.
Right. So I was like, why didn't we sell that ages ago? So we've always done that in physical therapy. So basically you take a stool, and the Squatty Potty is a good one, but you could use any stool, bricks, yoga blocks, whatever you have at home. And you want your feet to be high enough so that whatever the height is of your toilet, your knees are above your hips. And you're kind of leaning forward a little bit because that colorectal angle, it has to be more of like a squat. Imagine a squatting position, just sitting. Yep. So that the colorectal angle will open completely. And one interesting thing is I was talking to Dawn Sandalcini the other day, who specializes in pediatric incontinence. And she was saying that for pediatrics, a lot of times kids will think they're emptying their bowels, but then they'll have an x-ray and really they're not, because it's like the opening is too narrow. There's not enough relaxation of the pelvic floor. So in women who are pregnant, sometimes a similar thing can happen where it feels like you're having a bowel movement every day, but you're kind of straining it out. You're not really completely relaxing the pelvic floor. So that positioning is key. Sitting with your knees above your hips, but also being able to completely release the muscles around the pelvic floor and rectum. And in pregnant women, sometimes that's challenging because if you do start to develop incontinence, let's say you had some weakness going into your pregnancy. Now you've got the growing weight of the baby, shifted position of the bladder. Maybe this is your second baby and the first one was C-section and they cut the suspensory ligaments of the bladder, or you had, some kind of pelvic floor issue the first time. You may start having some incontinence. So you're going to be walking around kind of a little tensed all the time and forgotten how to completely relax. So instead of straining, the idea is to give yourself enough time, which is really challenging when you're the parent of a toddler or you're trying to get to work. Yeah. Give yourself enough time to sit on the toilet, sit completely and relax the pelvic floor. Also challenging for people who don't like to sit on public toilets or the toilet at work or something like that. So that bowel scheduling is also good. Drinking, you don't want to drink a lot of caffeine in pregnancy, but maybe a small glass of warm green tea or just warm hot water in the morning, warm or hot water in the morning, and have that time, because it is helpful to create a bowel schedule as well, where you're like, have that little bit of stimulation, whether it's breakfast, warm water, sit on a properly positioned toilet, have your knees high enough, completely relax for a minute or two, relax the pelvic floor and just breathe normally. And that's really kind of the ideal bowel routine for the morning. And if you've had enough movement, you've had enough, your blood sugar stayed steady, you've got good probiotic bacteria in your gut, you've had enough fiber, you've had enough hydration, all of those things we often have to think about in pregnancy, then everything should work fine.
Beautiful. What do you recommend for women if they get really constipated and are in quite a lot of discomfort? This is one of those TMI moments. I did have one of these situations in my early pregnancy with my second child. Didn't really ever have much in the way of constipation, traveled on a plane halfway across the world. Intense abdominal pain, really constipated. Anyway, got something from the pharmacist that basically flushed it all out. And I remember my entire family laughed at me as I did a happy poo dance. So we have to tell these stories to our patients.
Yes.
I'll just tell it to the world because it happens to all of us.
It does.
Anyway, any tips that you would give? So, in terms of those are more emergency situations.
Yeah. I mean, I think that if it is like you haven't pooped in 3 or 4 days or a week, and you're just in a lot of pain, number one, you can try that. Like do a little bit of stimulation, a small amount of caffeine, movement, get up in the morning, completely relax, sit on the toilet, do all the things I said, the fiber, the chewing, lots of water, physical movement. Even, I think Brienne Grogan, also blanking, and some of the yoga expert PTs that have YouTube videos have a couple of yogic pose videos online that will help with constipation. I know Brienne Grogan has some, and I think Dusty and Miller.
Yep.
So if you YouTube either of them, they probably have a few like sequences online for constipation. So try to get things moving, do it in that routine type of way, give it 24, 48 hours if you can. You can also do the I love you massage, which is essentially a bowel massage. I do that with
my children.
Yeah, where you kind of like move. So the colon is like in an upside down U And so you start by kind of releasing the left side. You just sort of generally abdominally massage the left side. Then you do the top and the left side. Then you do the right, the top and the left side. So that's an abdominal massage that can help things go. But, and also a reasonable dose of magnesium and or an Epsom salt bath, because Epsom salts have good amounts of magnesium that can be transdermally absorbed. And if none of that works, yes, sometimes we just have to do a reset, especially if it's sort of an acute situation like you had where you were on this transatlantic flight and, dehydrated or whatever, not mobile enough. Sometimes we have to do a reset and then get right back on that protocol. And if that was the case, I would recommend somebody go to their gynecologist. That's, just to make sure whatever you're doing is safe in pregnancy from a medical standpoint. And then, get right back on the horse of, the everything else that we just talked about.
Routine. Awesome.
Mm-hmm.
Well, that is heaps and heaps of information that you've given. So thank you so much, Jessica.
You're
if
welcome.
people want to learn more from you or find you, tell us a little bit about your website and your details.
Right. So the website is Integrative womenshealthinstitute.com.
Mm-hmm.
And we have professional training, which you can find right there, all the different kinds of courses that we offer. And we have kind of an introductory webinar to all of them, so you can learn more about each program. And then for patients who are not living right near me, we have a hormone balance program. We have a kind of do-it-yourself pelvic pain relief program. We've got a preparing for pregnancy program to optimize fertility and pregnancy health going into pregnancy.
Wow.
That's one other thing that I would suggest. If you are planning to get pregnant, do a preparing for pregnancy program, even if you don't have fertility challenges, because just getting your body sort of optimally resilient, and there are some things that we teach in that program to help optimize just the health of the eggs and sperm. It's actually, dads are involved in that program as well. It just sets you up for less complications, things like constipation or other issues in pregnancy. If you give yourself 3 to 6 months prior to conception to just, turn the lens on your own health and get ready for pregnancy. And I think this is almost even more important if you're on baby number 2 or baby number 3 or baby number 4, because a lot of times we
say that.
Yeah, you don't recover the first time. You're still barely awake, and it's okay, I'm pregnant again. Just take a deep breath, give yourself 3 months, get your systems really optimized as much as possible, and then you're just going to have much less challenge through pregnancy.
And I think that term postnatal depletion just works perfectly, especially with those women who have their babies back to back and don't really have the opportunity to fully recover mentally and physically. And I sort of jokingly say, look, your babies will literally they will suck everything out of you, out of your bones.
They will, yeah,
they take
from a physical standpoint.
And you're kind of left with whatever you're left with. And you need to rebuild and rebuild that nutritionally and rebuild your stock and your supplies in order to then grow another baby and then feed that baby and go through this process again. And I think when that process doesn't happen, then you start to really see some of those, those more inflammatory issues come up later, and more, chronic illnesses, which is very, very challenging when you have small children and then have that on top.
Yeah. And, it's very common to trigger autoimmune disease postpartum.
Absolutely.
And one of the reasons is that I think women just go into pregnancy so depleted. There's been one study on postpartum thyroiditis. Just having adequate selenium prior to and during pregnancy reduces that risk dramatically. It's at least 50%. So, really going into pregnancy, with some nutrient stores, some energy resilience, even fitness, because you can exercise safely to the level of your fitness during pregnancy. But if you go into pregnancy exhausted and depleted and unfit, it's only really safe to kind of lightly maintain. Yeah. So if we have a little extra fitness, then even if the first trimester you're kind of sleepy and nauseous, second trimester, when you get that blood doping, as we all know, you kind of
Mm.
double your blood volume second trimester, you can get back to it. So it's like pre-conception, think of that as 3 months. 3 months of first trimester, which some people breeze through, but other people do have kind of that fatigue, nausea. Just maintain, eat a little bit of food, keep yourself walking, sleep as much as you possibly can. And then by second trimester, often you feel a lot better and can maintain that strength and movement and nutrition going into third trimester and even labor and delivery and beyond.
Wonderful. Totally agree. Love it. Any final tips before you head off, Jessica?
I think that's it. I think that's
Brilliant.
plenty to do. Yeah.
Thank
And
you so much for your time, and hope you have a wonderful day in New York, and we will speak to you soon.
yes, thank you so much. Thanks for having me.